Sexual masochism disorder represents a complex paraphilic condition characterized by recurrent and intense sexual arousal from being humiliated, beaten, bound, or otherwise made to suffer, whether physically or psychologically. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, this disorder involves persistent fantasies, urges, or behaviors related to masochistic activities that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning over a period of at least 6 months. The condition distinguishes itself from consensual adult sexual practices by the presence of significant psychological distress or functional impairment. The clinical understanding of sexual masochism disorder has undergone substantial evolution throughout psychiatric history. Early psychoanalytic theories, heavily influenced by Freud's conceptualization, interpreted masochistic behavior as manifestations of unconscious guilt, self-punishment drives, or unresolved Oedipal conflicts. These early frameworks often pathologized all forms of masochistic sexual behavior without distinguishing between consensual practices and clinically significant disorders. Contemporary psychiatric approaches have embraced more nuanced biopsychosocial models that recognize the complex interplay between neurobiological predispositions, psychological factors, developmental experiences, and social learning processes that contribute to the development and maintenance of sexual masochism disorder. Individuals with sexual masochism disorder experience sexual excitement from various forms of suffering, including physical pain, psychological humiliation, bondage, discipline, or other forms of submission. The behaviors may range from relatively mild activities, such as being spanked or restrained, to more extreme practices involving significant physical harm or psychological degradation. The arousal pattern typically involves a need for increasingly intense or elaborate scenarios to achieve the same level of sexual satisfaction, potentially leading to dangerous escalation. Unlike consensual BDSM practices where participants maintain control and establish safety boundaries, sexual masochism disorder involves a compulsive quality that interferes with normal functioning. The onset of sexual masochism disorder often occurs during adolescence or early adulthood, though some individuals report masochistic fantasies beginning in childhood. Research indicates that the condition affects both males and females, though prevalence rates vary significantly across studies due to underreporting and definitional challenges. The disorder often follows a chronic course with periods of intensification during times of stress, relationship difficulties, or major life transitions. Many individuals with this condition report that their masochistic urges feel compulsive and unwanted, distinguishing it from consensual sexual practices. Neurobiological research has begun to explore potential brain mechanisms underlying sexual masochism disorder, though the field remains in its early stages. Studies suggest possible alterations in neurotransmitter systems, particularly those involving serotonin, dopamine, and endorphin pathways, which are crucial for pain perception, reward processing, and mood regulation. The relationship between pain and pleasure in masochistic arousal involves complex neurochemical processes, including the release of endorphins in response to pain stimuli. Neuroimaging studies have identified differences in brain regions associated with pain processing, reward systems, and impulse control, though more research is needed to establish definitive causal relationships. The psychological profile of individuals with sexual masochism disorder reveals several consistent patterns that inform clinical understanding and treatment planning. Many exhibit comorbid mental health conditions including depression, anxiety disorders, post-traumatic stress disorder, and substance use disorders. Research suggests complex relationships between childhood trauma, attachment difficulties, and the development of masochistic sexual preferences. Some individuals report that masochistic activities provide temporary relief from emotional distress, anxiety, or feelings of guilt and shame. The psychological function of masochistic behavior may include emotional regulation, stress relief, or attempts to gain control over traumatic experiences. Clinical assessment of sexual masochism disorder requires specialized training and careful evaluation by mental health professionals experienced in paraphilic disorders and human sexuality. The diagnostic process involves comprehensive interviews exploring sexual history, the nature and frequency of masochistic urges and behaviors, their impact on daily functioning and relationships, and associated psychological factors. Clinicians must carefully distinguish between sexual masochism disorder and consensual BDSM practices, which are not considered pathological when they do not cause distress or impairment. Assessment tools may include structured interviews, psychological testing, and evaluation of functional impairment. The stigma surrounding sexual masochism disorder presents significant challenges for clinical assessment and treatment engagement. Many individuals are reluctant to disclose their sexual behaviors due to shame, fear of judgment, or concerns about confidentiality. Some may only seek treatment when their behaviors have led to serious physical injury, relationship problems, or legal difficulties. This reluctance to seek help voluntarily often results in delayed intervention and increased risk of dangerous escalation. Building therapeutic rapport and creating a non-judgmental treatment environment becomes crucial for effective engagement. Evidence-based treatment approaches for sexual masochism disorder emphasize comprehensive psychological interventions targeting both the problematic sexual behaviors and underlying psychological factors. Cognitive behavioral therapy serves as the primary treatment modality, incorporating multiple therapeutic components. Cognitive restructuring addresses distorted thought patterns, beliefs about pain and pleasure, and schemas that maintain masochistic behavior patterns. Behavioral interventions focus on impulse control, alternative coping strategies, and gradual exposure techniques to reduce dependence on masochistic activities for emotional regulation. Dialectical behavior therapy has shown particular promise in treating sexual masochism disorder, especially for individuals with histories of trauma or emotional dysregulation. This approach emphasizes distress tolerance skills, emotion regulation techniques, interpersonal effectiveness, and mindfulness practices. The therapy helps individuals develop healthier ways of managing intense emotions without resorting to potentially harmful masochistic behaviors. Skills training focuses on building capacity to tolerate distress without engaging in self-destructive activities. Acceptance and commitment therapy offers another valuable approach by helping individuals accept their sexual urges while committing to behaviors that align with their values and overall well-being. This therapy emphasizes psychological flexibility, mindfulness techniques, and values-based action. Individuals learn to observe their urges without automatically acting on them and develop meaningful life goals that provide sustainable fulfillment beyond masochistic activities. The approach particularly addresses the shame and self-criticism often associated with sexual masochism disorder. Trauma-informed therapy represents a crucial component of treatment for many individuals with sexual masochism disorder, given the high prevalence of childhood trauma and adverse experiences in this population. Therapeutic approaches such as cognitive processing therapy, prolonged exposure therapy, or eye movement desensitization and reprocessing may be integrated into treatment plans. These interventions help individuals process traumatic experiences, reduce trauma-related symptoms, and develop healthier coping mechanisms that do not involve potentially harmful sexual behaviors. Group therapy can provide valuable peer support and reduce the isolation commonly experienced by individuals with sexual masochism disorder. Carefully facilitated groups allow participants to share experiences, learn from others who have successfully managed similar challenges, and develop supportive networks. Group interventions often focus on developing healthy coping skills, addressing shame and stigma, and building self-esteem. However, group therapy requires expert facilitation to ensure appropriate boundaries and prevent inadvertent reinforcement of harmful behaviors. Pharmacological interventions may be considered as adjunctive treatments for individuals with severe symptoms, high levels of sexual preoccupation, or significant comorbid mental health conditions. Selective serotonin reuptake inhibitors can help reduce obsessive thoughts, compulsive behaviors, and overall sexual preoccupation while addressing comorbid depression and anxiety. Mood stabilizers may be prescribed when bipolar disorder is present. In some cases, medications that reduce overall sexual drive may be considered, though these require careful medical monitoring and consideration of potential side effects. The relationship between sexual masochism disorder and physical safety represents a critical clinical concern. Some masochistic practices involve significant risk of serious injury or death, particularly those involving breath play, extreme bondage, or severe physical punishment. Clinicians must carefully assess safety risks and work with individuals to reduce dangerous behaviors while addressing underlying psychological needs. Safety planning becomes an essential component of treatment, including education about risk reduction strategies and development of alternative coping mechanisms. Cultural and social factors significantly influence the manifestation and treatment of sexual masochism disorder. Different cultures have varying attitudes towards sexuality, pain, and alternative sexual practices, which can affect both the development of masochistic behaviors and individuals' willingness to seek treatment. Treatment programs must demonstrate cultural sensitivity and consider these factors when developing intervention strategies. The increasing visibility of BDSM communities has also influenced how masochistic behaviors are understood and addressed clinically. Prevention efforts for sexual masochism disorder focus on early identification of risk factors and providing appropriate interventions before behaviors become compulsive or dangerous. Educational programs addressing healthy sexuality, trauma recovery, and emotional regulation skills may help prevent the development of problematic masochistic behaviors. Mental health professionals emphasize the importance of addressing childhood trauma, attachment difficulties, and emotional regulation problems that may contribute to the development of sexual masochism disorder. Contemporary research into sexual masochism disorder continues to evolve, exploring new understanding of neurobiological mechanisms, psychological factors, and treatment approaches. Studies investigating the relationship between trauma, attachment patterns, and masochistic sexual preferences provide insights into developmental pathways. Research on the effectiveness of various therapeutic interventions helps establish evidence-based treatment protocols. Longitudinal studies examining treatment outcomes and factors associated with recovery inform clinical practice and policy development. The impact of sexual masochism disorder extends beyond the individuals directly affected to include partners, families, and relationships. Partners may struggle with understanding, accepting, or participating in masochistic activities, leading to relationship conflicts and distress. Family members may experience confusion, concern, or distress when learning about their loved one's condition. Couples therapy and family interventions can help address these relationship challenges while supporting treatment goals. Looking toward the future, the field continues to emphasize comprehensive, evidence-based treatment approaches that address both the masochistic behaviors and underlying psychological and social factors. Success requires integration of various therapeutic modalities, attention to safety concerns, and consideration of individual needs and circumstances. The ultimate goal remains helping individuals develop healthy ways of managing their sexuality and emotions while reducing harmful behaviors and improving overall quality of life. Treatment approaches continue to evolve as understanding of sexual masochism disorder deepens through ongoing research and clinical experience.